Buenas noches. Hoy, como todos los meses, estamos de celebración. Estamos en la sesión mensual de la Asociación Mexicana de Gastroenterología. Hoy hay una doble celebración. El hecho de poder compartir con todos ustedes una plática interesante, pero además poder celebrar juntos los 40 años de fundación de la Sociedad de Gastroenterología de Tamaulipas. Y sin más preámbulo, les dejo con ustedes a la presidenta que amablemente ha accedido a presentarnos una sesión de lujo, la doctora Maldonado. Alma, bienvenida. Y a todos los demás, bienvenidos. Hagan preguntas. Es para celebrar esto. Adelante.
Muchas gracias, doctor. Muy buenas noches. Es un gusto estar con ustedes y agradecemos mucho a la Asociación Mexicana de Gastroenterología el espacio para poder conmemorar con ustedes nuestro 40 aniversario de fundación. Les damos la bienvenida con esta postal de lo que es la Expo Tampico, el centro de convenciones en el sur de Tamaulipas. Nuestra sociedad nace en 1981 ante la inquietud de varios especialistas, gastroenterólogos, cirujanos, principalmente, tenían la inquietud de difundir los conocimientos de la gastroenterología y aumentar el acervo de la misma. Encabezados por el doctor Héctor Hernández López, se convocó a la Asamblea Constitutiva y en representación de la Asociación Mexicana de Gastroenterología en aquel entonces, acudió el doctor Jorge Bautista O'Farrill, dando el visto bueno a la Asamblea, al quórum, y queda fundada la Sociedad de Gastroenterología de Tamaulipas en 1981. Esta sociedad pues ha reunido especialistas, cirujanos, cirujanos oncólogos, anatomopatólogos, obviamente gastroenterólogos, coloproctólogos, ¿verdad? A los 20 años yo regreso a lo que después de mi especialidad, 2 años después me integro a la sociedad y pues nuestra última sesión presencial fue en diciembre del 2019, después se viene la pandemia y pues no ha sido posible más que por vía virtual estar acompañándolos en las sesiones mensuales, ¿verdad? Esperemos que esta convivencia que se dio en diciembre del 2019 la podamos hacer ahora en Guadalajara el próximo noviembre para poder celebrar todos juntos este 40 aniversario. Aprovechando la oportunidad, pues tenemos gracias al doctor Juan Carlos Caramés, tenemos unos ponentes de gala a nivel internacional reconocidos y iniciaremos, está el doctor Kahaleh, el doctor Prashant Kedia y representando a nuestra sociedad el doctor Juan Carlos Caramés con endoscopía avanzada. Iniciaremos la plática con el doctor Kahaleh.
Our first speaker, as I said, is Dr. Kahaleh, who will speak about the utility of endoscopic ultrasound in gastroenterology. He heads the gastroenterology clinic and head of endoscopy, head of the pancreas program, all of this at Rogers Wood Johnson University Hospital, located in New Jersey, the United States. Welcome, Dr. Michel. You have the floor. Hello, it's an honor and a pleasure to participate in this meeting. I'm going to speak about treatment endoscopic ultrasound in 2021. When we speak about the evolution of therapeutic endoscopy, everything began as with diagnosis. It began as a diagnostic technique. Then we started taking biopsies, and then we started making injections like the celiac plexus block. And then we started doing interventions with endoscopic ultrasound. Let's speak about the drainage for pancreatic fluid collection, bile duct drainage, and gallbladder drainage. Then we'll speak about the creation of anastomosis and a little bit about ablation. When we speak about peripancreatic fluid collections, we know that 5 to 15% of patients with pancreatitis will develop a peripancreatic fluid collection. It may be, if it is symptomatic or infected, it will require a drainage. Clearly now, we have many publications and evidence showing that drainage is our preferred technique. This is a very interesting study comparing minimally invasive surgery with the endoscopic ultrasound therapy for the drainage of peripancreatic fluid collections. It has proven to have less fistulas and less complication if one uses endoscopic ultrasound. This is a fluid collection with the appropriate approach. We place a guide wire and we work on that guide wire to place a stent. In this case, we use an apposition stent. This is the Axios stent. Where the Axios stent is displayed, then we can make the drainage. This is it's wonderful that endoscopists can offer this drainage because it solves infections in situations that used to require percutaneous drainage or surgery. When we speak about complicated collections like wall of necrosis, we may visualize the stent, for instance, the apposition stent or the esophageal stent. We can see that we have the possibility of opening the gastric wall, going in and offering necrosectomy. So we have to consider this stent as a window that allows us to get inside the collection and then offer an efficient lavage. This is the power that these stents have and we can place them with endoscopic ultrasound in a safe way and avoiding the blood vessels that are in front of these collections. Whenever we speak about biliary drainage, we need to remember that 3 to 5% of the patients with biliary obstruction cannot undergo the conventional ERCP because of an altered anatomy or because a diverticulum or diverticuli or gastroduodenal obstruction. So we need to think about a different modality. For instance, endoscopic ultrasound if we want to offer drainage, because percutaneous drainage involves a lot of complications and a high morbidity rate. We currently have a lot of data. This technique has been in place for more than 20 years. There are multiple randomized controlled trials about this technique that has proven to be effective, to be safe, and it is with equivalent outcomes amongst the groups. In cases in which ERCP may be more dangerous and we need to avoid cutting, we need to offer drainage. So this is an interesting approach. We have two techniques. We may use an intrahepatic or an extrahepatic technique. We may place a stent that may be placed in a transpapillary approach or transgastric if we are doing an hepatogastrostomy. Or you may use an extrahepatic technique when you place a stent with a choledochoduodenostomy anastomosis. This is the intrahepatic approach. With the transgastric approach, we're going to inject, we're going to go into the patient's anatomy. In this patient, it was impossible to get all the way to the papilla because there was duodenal obstruction that prevented us from doing it. So the first step is opacification in order to understand the anatomy and check exactly where the obstruction is. We play with the guide wire, we advance it, and we achieve stable access. When one achieves a stable access, one can work on the guide wire. We can place a balloon and we can dilate the bile duct. This way, we can have much better stability to play with the guide wire now that the balloon is dilated. When the guide wire goes through the biliary obstruction, we start advance the balloon dilated and working on the guide wire. We're going to place a stent. This is done here through the stomach. We are coming to the bile duct through the stomach, and we go across the papilla or across the tumor lesion. With an antegrade approach, we can display the stent and provide an efficient drainage. When we speak about gallbladder drainage, we have to remember that cholecystectomy is still the gold standard for cholecystitis. However, there are patients who cannot undergo this kind of surgery because of comorbid conditions or because they have unresectable cancer. So percutaneous drainage represents a problem for these patients because it impairs their quality of life. We have to remember that percutaneous drainage involves high morbidity and mortality rates. This is a meta-analysis done by my friend Todd Barron. In this case, he analyzed all of the techniques for draining the gallbladder. He shows that the side effect rate is extremely important and they are reduced if you use endoscopic ultrasound guided drainage. But we have to think about something else. When we consider all of the available techniques for gallbladder drainage, we need to use an international approach. We conducted this study, including 155 patients and 7 centers from all over the world. We were able to compare endoscopic ultrasound guided gallbladder drainage with 113 percutaneous gallbladder drainages. There were no differences in the clinical results, side effects, and most important, there were fewer repeat interventions in the group where endoscopic ultrasound was used. In 34 patients, we were able to show that offering an endoscopic ultrasound drainage does not represent a problem for later surgery. So up to now, if we cannot offer immediate surgery, we can drain the gallbladder percutaneously and then surgery. However, we now have evidence showing that we may offer an endoscopic ultrasound guided drainage and then refer the patient to surgery. The technique is very similar to the pseudocyst drainage technique. This is an approach using a fine needle, and then we inject the contrast medium and more saline solution, and now we're going to drain the gallbladder using a transduodenal approach. It is important to remember that once in a while, since the gallbladder is collapsed, you can distend it with saline solution, and this facilitates the drainage. And this is something important that we have to remember. In cases in which the gallbladder is not that big, you need to distend it or to inflate it, and this is very helpful. In this case, we use the Axios technique, and it is a single step technique once you have distended the gallbladder. After this, we can go ahead and place the Axios stent very simply. Then we open an internal window. We position the gallbladder wall against the duodenal or gastric wall. And after that, we open a second window and we can drain. Once in a while, you can go back, remove stones. So this is a very, very satisfactory procedure for gallbladder drainage. In the case of obesity, we have many patients who present with a gastric bypass, but if this patient requires ERCP, this is almost impossible. We attempted a technique when I was still in New York in which we connected the excluded stomach to the pouch. This helped us avoiding the need for going to the OR, performing an endoscopic procedure, and so on. When we published this paper, we were very, very happy because we were able to establish a laparoscopic access. We did not need to establish a laparoscopic access. That's why we call this technique game over. There are many studies about this technique. We can say that in the US, this is a primary technique when we need to perform ERCP in patients who present with a gastric bypass. When you compare EDGE with ERCP done with laparoscopy, you know that EDGE is a quicker procedure, less expensive, and when you compare it with other techniques, EDGE appears to be simpler, it takes less time. The patient has to stay at the hospital for a shorter period of time. And Ted Barron conducted this cost effectiveness analysis that showed that EDGE is a less expensive technique. This is a patient here with a gastric bypass. In the pouch, we will identify the excluded stomach. Then we're going to inject the excluded stomach. We distend it, dilated, and after dilation, we place an apposition stent that's going to help us perform ERCP. And this truly facilitates everything. Another indication for endoscopic ultrasound is to perform EUS-guided gastroenterostomy. This is a minimally invasive procedure that allows the patient to eat if he or she has terminal cancer. And we are trying to replace little by little the enteral stents that involve many complications. And after a certain period of time, they don't work because the cancer invades the mesh of the non-coated or non-covered stent. We have this study with including 26 patients. And another way of measuring the efficiency and comparing gastroenterostomy versus lap gastrojejunostomy. I'm showing this a multi-center trial that we conducted with other groups. And this is the Hopkins study. Both studies showed exactly the same. The success rate is the same for both techniques, but the EUS-guided gastroenterostomy is a less expensive and safer procedure. Something else that is important to compare is this technique with the enteral stent. The gastrojejunal anastomosis or gastrointestinal anastomosis appears to be much better with a lower recurrence rate and less re-intervention rate because we are establishing a connection that is outside. And this is a very important concept. This is the case of an 86-year-old woman with pancreatic cancer. An enteral stent had been placed, and we can see that unfortunately this patient would come back with gastrojejunal obstruction, and every time she needed an additional access in order to be able to eat and avoid gastrostomy. So the first thing that we are going to do for this patient is to have access to the small bowel. We are placing a guide wire here that is going across the entrance stent that is occluded. And then over this guide wire, we're going to advance a balloon catheter that will help us to, we're going to use this balloon catheter that will be filled with contrast medium mixed with water. This balloon, which is now in the small bowel, is going to be used to make a puncture from the stomach. This way, we're establishing a gastrojejunal connection. If we inflate the balloon, we know that we are already in the small bowel. Once that we have access, we're going to place a guide wire, and over the guide wire, we're going to dilate and place an apposition stent. This was the time when, at the time when this video was shot, we did not have the apposition stent, so we used a balloon. After we have inflated the balloon, we place an apposition stent between the small bowel and the stomach. Now we can see that after dilating, we achieved a very nice connection between the stomach and the small bowel. In managing complications, this is critical. At times, we have to place a bridging stent, or we have to convert to a different axis. This is a case in which, during the gastroenterostomy, the apposition stent caused a lot of lesions, and it went through the gastric wall. But we were reassured because we already have a guide wire. We decided to place a short stent in the esophagus that is going to act as a bridging stent. This was a salvage procedure for this patient, and it allowed the patient to eat without any problems. So the bridging stent technique is a critical technique that you need to be able to handle if you want to offer the patient a gastrojejunostomy with endoscopic ultrasound. This is another case in which, during the procedure, we realized that when we were going through the small bowel, there was an obstruction. So we suddenly were in front of the peritoneum. In these cases, you need to keep calm and think about the bridging technique. However, in this case, we're going to use two channels, and we're going to take the intestinal loop. We're going to do a pre-cut with a pre-cut needle. And here, this way, we are going to reestablish an access in the intestinal loop. This is how we are doing it. We are injecting contrast medium to make sure that we are truly inside the small bowel. After that, we're going to place another bridging stent using the nodes technique. So once again, we were able to salvage the procedure and salvage the patient because we offered a durable and efficient anastomosis that allowed the patient to eat. To close, I would like to address pancreatic cancer, which represents a big problem in our country. In patients who cannot undergo a resection, it's interesting to be able to offer ablation. This is a video from Korea. Professor Seo is a world expert on ablation for pancreatic cancer. We can see that with the endoscopic ultrasound control, we can really see where is the effect of radio frequency, which is very important. We don't have a lot of data nowadays. However, it appears to offer a good result, particularly for neuroendocrine tumors. in the case of patients who cannot undergo surgery, this is a technique that is very useful that helps treat neuroendocrine tumors. In conclusion, we can say that therapeutic endoscopic ultrasound is an exciting, rapidly expanding field. It helps us to improve the management of many problems that used to require surgery or percutaneous drainage. This kind of technique is improving every day, and we see an incredible future for endoscopists who are interested in endoscopic ultrasound guided therapies. I would like to thank all of you for your attention, and I will be available to entertain your questions. Many thanks, Dr. Kahaleh. This was a very interesting presentation. I would like to remind participants that at the bottom right of their screen, they have the Q&A chat box where they can write down their questions. In keeping with our agenda, allow me to introduce Dr. Prashant Kedia, who will speak about bariatric endoscopy, the advantages of endoscopic gastric sleeve. He's the medical director for interventional endoscopy at Methodist Medical Center in Dallas, Texas. Welcome, Dr. Prashant Kedia.
Thank you to the Mexican Association of Gastroenterology for having me speak here today. I'm very honored to speak on this topic of bariatric endoscopy. My name is Prashant Kedia. I'm the medical director of interventional endoscopy at Methodist Dallas Medical Center. I'm going to be speaking on endoscopic sleeve gastroplasty and focusing on the benefits of that procedure today. Since this is a short lecture, I'm going to get right into it. So what are the benefits of endoscopic sleeve gastroplasty? Well, it's minimally invasive. It provides more options and access to obesity therapy. It's clinically effective in achieving meaningful weight loss. It's safe, has less adverse events than bariatric surgery, and has less acid reflux. It's cost effective. It's repeatable and revisable. And it has potentially multiple applications, including primary, revisional, and bridge therapy. So through this lecture, I'm going to try to convince you of all of these benefits. So let's talk about it being minimally invasive. As we know, this is an endoscopic procedure that was conceptualized in 2013 by the Mayo Group. And the concept here was to use a endoscopic suturing device to mimic a surgical sleeve gastrectomy. But instead of cutting away the greater curvature of the stomach, the goal is to use this suturing device to plicate the greater curvature and reduce the volume of the stomach into a slender banana shape. This was images from their first publication showing the size of the stomach before and after ESG and the remodeling effect, which was pronounced that they found in the stomach 3 months later. The device that we use to perform this procedure is called the Apollo overstitch device. It generally fits over a double channel therapeutic endoscope, although there are single channel devices now. And it's a very amazing, fantastic device that really allows us to do dramatic tissue manipulation using the tip of an endoscope. It was originally designed for stent fixation, closure of perforations and fistulas, but because of the dramatic tissue manipulation ability, we're able to pivot this into performing bariatric procedures such as endoscopic sleeve gastroplasty. So how do we perform ESG? As you know, this is not a surgical procedure. There's no cuts or incisions. The entire procedure is performed with an endoscope intraluminally. And a double channel therapeutic endoscope is advanced to the stomach. And the anterior and posterior borders of the greater curvature are marked with APC using argon plasma coagulation. Subsequently, the overstitch device is used to purchase tissue using full thickness purchases of the gastric wall, starting distally and then moving proximally towards the fundus. And as you can see, usually about 6 to 8 purchases of tissue with each suture, which can then be plicated and reduce the total volume of the stomach, starting at the greater curvature. As you can see here, by moving forward and proximally towards the fundus, you can dramatically reduce the volume of the stomach by 60 to 70% with this procedure. Here is a video of what this looks like in an actual endoscope. So here's a large gastric lumen. And the first thing we do with this procedure is to use the APC. This is usually a straight fire APC stomach settings, using to mark the anterior and then posterior borders of the stomach. So here is the posterior border of the greater curvature. And the reason these markings are important is because as you do the procedure, there can be blood that kind of gets into the field that can make you lose your orientation. So having these markings really helps you understand where you need to place your tissue purchases. In this particular procedure, the endoscopist is using not only anterior and posterior, but placing some markings in the center between them to further help with orientation. After the markings have been created, the overstitch device is placed over the endoscope, and then the sutures are loaded. Once you take your first purchase, that helix device there on the left is very important. It looks like a corkscrew that's able to twist and pull the tissue into the jaws of the overstitch so that you get a full thickness purchase. That is very crucial to the success of this procedure because you want those tissue bites to go through the muscularis propria of the stomach. Without going through the muscularis propria, you risk having a non-durable sleeve and without having significant remodeling. And so here, full thickness purchases are being made. A cinch is used to tighten the sleeve, the purchases. And here you can see how slender the stomach looks afterwards. By reducing the volume of the stomach dramatically like this, the way that this works is that we induce satiety for patients. Studies have shown that patients only need about 30% of the calories they needed prior to the procedure to feel satiated, and that reduces their oral intake. It also delays their gastric emptying. Studies from DDW this past year showed that there was a significant, markedly increased delay in gastric emptying after ESG. All of these together will assist with behavior modification. The next benefit is that it improves access to care. This is a CDC map looking at obesity rates in America. And as you can see here, obesity rates are skyrocketing. In America, 1 out of 3 patients is obese. This is not just an American problem. This is a worldwide problem. Obesity rates are skyrocketing around the world. Over 650 million people were obese in 2016. And this is becoming a generational issue, not just for us, but for our children as well. And the only other country in the world that's more obese than America is Mexico. And that is because you guys have such good food. And I wish I was there actually to enjoy it this time, but hopefully next year. And so when we talk about access to care, bariatric surgery is the mainstay of treatment for obesity. On a risk efficacy graph here, it has the most risk, but it also has the most efficacy, and has been shown in multiple studies to be effective and durable. Swedish obesity study, amongst other studies, have shown long-term durable weight loss with the surgery, reduced cardiovascular mortality, reduced cancer mortality, improved diabetes remission. So it's so effective. Why aren't more patients getting this done? Well, let's talk about who has access to surgery. So in terms of Americans, class 1 obesity patients do not qualify for bariatric surgery. You have to be class 2 obesity with at least 1 to 2 comorbidities, or class 3 obesity. And of those patients that do qualify, less than 1% will actually undergo bariatric surgery. Why is that? Well, part of it is that patients are just worried about surgery. They find it significantly invasive. They find that there are the complication rate that they're not willing to undergo. They worry about needing revisional surgeries. And so these are real fears for patients which prevent them from getting these things done. And that leaves us with a treatment gap of about 100 million obese patients in our country that either don't have access to care or are unwilling to undergo care. And this is where endoscopic therapy may be able to bridge and fill that gap. So what we've known now is that ESG is clinically effective. Over multiple thousands of ESG have been performed around the world with very consistent, reproducible results. This is probably the earliest large case series that was published on ESG from Dr. Kahaleh's group amongst other international centers. 242 patients, two-year follow-up, about 15.1% total body weight loss at 6 months, and up to 18.6% at 24 months. And we'll talk about these side effects, which are mild and few in a bit. This data has been reproduced around the world at multiple different centers in US, Spain, and Saudi Arabia. Again, it's very consistent, 15 to 20% total body weight loss, very low serious adverse events. And a recent meta-analysis, again, also shows almost 1,900 patients, 16.4% total body weight loss at 12 months and 20% at 24 months. So we know that this is effective no matter what the setting if done properly. Again, here, low adverse events and no mortality. But just because we can achieve weight loss doesn't mean that it actually is affecting their overall health, their comorbidities. So that's very important as well. Two studies now have shown that ESG does improve comorbidities related to obesity, including waist circumference, systolic blood pressure, markers of metabolic syndrome and diabetes, hemoglobin A1C, insulin resistance, triglycerides, and also fatty liver, which is a big thing now going forward. ALT markers, HSI indexes, and NAFL fibrosis scores. So there is meaningful weight loss with comorbidities related to ESG. Again, another question is, what's the long-term durability of ESG? This is still in evolution, and I think we need more data. One study last year was published showing 5-year data of ESG, showing 15.9% total body weight loss at 5 years, which is fantastic. The early success in these patients was predictive of long-term success. Another benefit of ESG is that it's safe. It has less adverse events than conventional bariatric surgery. Again, in that meta-analysis that I talked about earlier, the pooled serious adverse event is 2.3%. In most studies, it's less than 1 to 2%. And the vast majority of all of these complications are managed non-surgically. And there's no mortality to date in these meta-analysis. So that's very good outcomes. Some comparative studies looking at ESG versus laparoscopic sleeve gastrectomy, or LSG. In this New York study, they showed that the length of stay was much lower for ESG, 3 versus less than 1 day. And the total morbidity, 2.2% versus 9%. So significant less adverse events. 90-day readmissions was also higher for LSG versus ESG, but not statistically significant. In a Johns Hopkins study looking at the same thing, ESG versus LSG, we know that laparoscopic sleeve results in more total body weight loss, but it also has significantly higher adverse events and also significantly higher post-op acid reflux. Acid reflux is a significant complication after LSG. Up to 30%, 50% in some studies show that patients will encounter some degree of acid reflux after LSG, and partly because of the decreased gastric compliance, neurohormonal pathways, manipulation of the angle of His, which is not as pronounced in ESG, right? Because we don't close the fundus, we have more gastric accommodation, and potentially those differences in less aggressive nature result in less postoperative GERD, which is a significant benefit. In this Spanish study, they looked at the same question, ESG versus LSG. They found, again, less adverse events in the ESG arm, and also, again, a shorter length of stay, as this is an outpatient procedure. So let's talk about cost efficacy. So I think this is a loaded question, and the problem is that there's really no data published on this. There's no comparative data or data on ESG really looking at this. So we're going to have to extrapolate this from the literature that's already been published. I think you can split costs into direct costs of the procedure and then indirect costs over time related to the procedure. So if you look at procedure-related costs, including the device, physician fees, et cetera, generally ESG procedure costs are around $5,000. If you look at the literature for LSG, direct costs in terms of that is about $9,000 to $10,000. So ESG is cheaper in terms of direct costs of the procedure itself. In terms of hospitalization and length of stay, we already know ESG is an outpatient. It has a lower length of stay than laparoscopic sleeve, so it should have a lower hospitalization and length of stay cost. Also, in terms of adverse events and readmissions, we've shown that ESG has fewer adverse events than LSG, and it's a trend towards less readmission. So I think there's going to be a more cost benefit here as well. And then in early health utilization, this is talking about hospital visits, office visits, reoperations, et cetera, in the first 1 to 5 years after a procedure. In LSG, one study was able to quote about $25,000 of healthcare utilization in the first 5 years. Much of that care is actually incorporated into the global ESG cost. So I still think ESG is actually going to win in this early healthcare utilization. Now, the question is, what about the indirect cost benefit over time? Quality adjusted life years, patient productivity, patient employment, long-term health utilization, especially if there's an improved cancer, cardiovascular mortality, et cetera. We don't know what's going to be more cost effective in the long term, and that's yet to be seen. Another benefit of ESG is that it's repeatable and revisable. So weight regain after bariatric surgery has been reported in up to 25% of cases. and up to 27.8% for laparoscopic sleeve. And these numbers are going to be similar and have been shown to be similar for ESG in early data. But the nice thing about ESG is that it can be redone. A redo ESG or retightening of the sleeve is safe and possible. Multiple studies now have been published on this, showing an incidence rate of 3.3 to 7.7% of patients requiring redo ESG for weight regain or weight failure of loss. Average 3 to 5 sutures per procedure. The time to redoing them is early, usually in the 10 to 22 months after the initial procedure. So the failures present early, and the total body weight loss after a redo ESG is 11.2 to 20.4%. So significant weight loss and no significant adverse events. So this is a very real option for patients that are regaining weight or did not lose enough weight to begin with to just retighten that sleeve with a minimally invasive outpatient procedure. Other options are conversion of an ESG to a laparoscopic sleeve and Roux-en-Y gastric bypass. Case reports on this have been published and have been shown to be safe, so this is another option for patients. Recently in DDW, they published data on redo ESG versus use of pharmacotherapy for patients that are having weight regain, and they showed that redo ESG was superior, 19.9% total body weight loss versus only 13.6% for pharmacotherapy. So redo ESG seems like a very good option for these patients. And then the final benefit is that ESG has multiple applications. We've already talked about how it can be a primary therapy for obesity, but there's also options for using it to revise other bariatric surgeries, such as LSG. This was a international study of 82 patients that had weight regain after a laparoscopic sleeve due to stretching of the sleeve or whatnot. And they were able to show in a 48.3-minute procedure, median of 4 sutures, triangular stitch pattern, they could achieve 15% total body weight loss at 1 year with 1% serious adverse events. So this is a very nice, minimally invasive option to regain some weight loss in patients that are after a laparoscopic sleeve and gaining weight. And then finally, ESG could be considered as a bridging therapy for bariatric surgery in very super obese patients that may not be good surgical candidates to begin with. So if a patient is not a good surgical candidate, maybe we can use ESG to make them lose weight and bridge to surgery. This is a case series of 5 patients, BMIs in the 51 to 72 range. They used ESG to reduce the BMI by greater than 6 and help bridge them to surgeries. So in conclusion, the obesity epidemic is real and it's growing. There's a large gap in treatment between pharmacotherapy and bariatric surgery, which could potentially be filled by endobariatric procedures. ESG is gaining popularity both with providers and with patients, and it has multiple advantages and benefits, which include being minimally invasive, provides more access to care, it's clinically effective, it's safe, it's cost effective, it's repeatable, it's revisable, and it has multiple applications. I think future directions that are needed for ESG is that we need higher quality randomized controlled trials, more data on the long-term outcomes, and then some personalized medicine to predict responders to optimize patient selection. Thank you for your time.
Many thanks, Dr. Prashant Kedia. This was a very interesting talk. We know that obesity is on the rise, so this was very relevant. Our next speaker is Dr. Juan Carlos Caramés, who is an active member of the Gastroenterology Association in the state of Tamaulipas. He is director of the Advanced Therapeutic Endoscopy Center in Reynosa, Tamaulipas. He will speak about submucosal endoscopic dissection in Mexico. Welcome, Dr. Juan Carlos. I would like to remind the participants to please send over any questions they may have using the Q&A chat box. Go ahead, Dr. Caramés.
¿Qué tal? Muy buenas noches. Es un honor y un
Good
privilegio.
evening, everyone. It's an honor and a privilege for me to give this talk this evening and to share with you the celebration of the 4th year anniversary of the Association of Gastroenterology of Tamaulipas. It's my pleasure to speak to you about endoscopic submucosal dissection ESG. To be able to perform ESG, we first of all need to diagnose lesions that are amenable to be treated with these techniques. For this, we need high definition endoscopes, and we may usually use electronic chromoendoscopy or magnification chromoendoscopy or staining or dyes. We may also magnification may be used to make the diagnosis of low-grade dysplasia, high-grade dysplasia, or carcinoma in situ that might lead to performing endoscopic submucosal dissection (ESD). We may also treat submucosal lesions, and for this we need high-definition endoscope, and we will require endoscopic ultrasound to make the diagnosis. What can we obtain with electronic chromoendoscopy and magnification? This is a lesion that might be an ulcer, or it could be considered as an ulcer. But when we apply electronic chromoendoscopy and magnification, we can see the details on the surface, leading us to make a very precise diagnosis. It provides us with a very certain diagnosis and helps us identify lesions that are amenable to being treated endoscopically through ESD. This is using white light that allows us to detect what appears to be erosive esophagitis in a patient with GERD. When we apply electronic chromoendoscopy, we see in this area that we have areas of intestinal metaplasia. With magnification, we may see that there are areas with low-grade dysplasia that can be treated with ESG. The Japanese have prepared a classification where they identify the microvascular pattern and the microsurface pattern. This is the regular vasculature and a regular microsurface pattern. In this case, this is only low-grade dysplasia. Here we can already see an irregular both microvascular and microsurface pattern with lesions suggestive of pre-malignant changes. When there is complete absence of the surface pattern and absence of the microvasculature, and we also see the demarcation line of the lesion, then we may make the diagnosis of early cancer that is amenable to endoscopic submucosal dissection. We said that early diagnosis is necessary, and what do we need for this? Of course, high definition endoscope. Most of the companies that sell endoscopes have a high definition as part of them. Most of them have available these virtual chromoendoscopy diagnostic methods that I'm showing here, and we may also use magnification endoscope to make a precise diagnosis. The CAP is very useful. It is essential because it allows us to have the lesion at 2 to 3 millimeters of distance, providing better magnification, and we can we can see the image with a better resolution. Of course, we need irrigation, like the water jet, to be able to clean the surface perfectly well and avoid saliva, food remains, bile, or blood that we may encounter. Obviously, the entire team, and not only the endoscopists, but the entire team should be properly trained. And an important point is that we need to dedicate the time necessary to look for these lesions. This is how we can make precise diagnoses. On this video, we can see that with white light, we can see a lesion that is evidently altered. With chromoendoscopy and magnification, we can identify low-grade dysplasia that requires treatment with ESG. There are classifications that help us determine which lesions are amenable for ESG. We have the Paris classification that helps us identify 2A or 2B lesions that are slightly elevated lesions or flat lesions. 2C lesions are depressed lesions without an ulcer. Type 3 lesions are ulcerated, excavated lesions that are not amenable for endoscopic treatment, and mixed lesions or with a mixed classification have the indication of endoscopic submucosal dissection. This occurs for 2B. 2A lesions may be treated with ESD or EMR. In the case of mixed lesions, there are 2A plus 2C or 2C plus 2A. ESD is also indicated. Looking at this timeline, we may feel very proud of so many courageous endoscopic physicians that started the journey from only diagnostic endoscopy, going through polypectomy initially, then endoscopic mucosal resection or EMR, then endoscopic submucosal dissection ESD, the notes technique, and finally the use of third space techniques, beginning with per-oral myotomy or POEM. Thanks to this, we have had access to what we call the third space, and we can offer to our patients not only endoscopic dissection of early lesions, but also of tumors that are beyond the gastric wall. Let's speak about endoscopic resection of the mucosa, EMR, indicated for GI premalignant and malignant lesions, particularly at the level of the colon and rectum lesions without deep invasion. They are limited to lesions that are 1.5 to 2 centimeters in length. Eh, Larger lesions may be resected using the piecemeal technique. There is the technique limitation for block resection. There is a limitation for resection of R0 lesions, and the EMR involves higher chances of relapse. In the case of endoscopic submucosal dissection ESD, it allows to perform unblocked resection. It has a very low recurrence rate. We can perform curative resection. When EMR is not possible or fail, we have the option of ESD. It allows us to get the full specimen for proper histopathology and perform curative treatment in the case of R0 lesions. It preserves the integrity of the organs. This means we're going to resect one part of the mucosa and submucosa, or at times that we will see later, we will be able to resect submucosal lesions that will allow us to provide better quality of life to the patient without the need for full organ resection. ESD is indicated for early cancer, whether the one that is limited to the mucosa or to the superficial submucosa, that is to say T1A lesions, where there is a low risk of lymph node invasion and a high chance of survival. There are no size limits for the dissection of these limits. We may dissect lesions that are R0. Of course, greater endoscopic skills are required, longer training, and more equipment and accessories that we should always have at hand, not only to be able to perform the dissection, but also to address the possible complications of this technique. This is a relatively recent technique for subepithelial lesions. We may perform ESD in tumors that are more than 2 centimeters in diameter, that are limited to the submucosa or the muscularis propria. It may be used for mobile lesions that may be resected in 100%, or fixed lesions that are in deep planes. 75% of them may be dissected, but there is the risk of perforation of bleeding. So we need to have additional equipment and accessories to address these possible complications. This slide shows the kind of equipment that we need to perform ESG. It's not that we are going to always use everything, but these are things that we should have at hand. Patients are treated with the general anesthesia. We usually need an overtube because we will need to go in and out several times. We need a CO2 insufflator, which is essential. We cannot perform ESG if we don't have CO2 because the chance of perforation or serious complications may occur. Preferably, we should have advanced electrocoagulation equipment like ERBI Bio 300D. If possible, we should have the ERBI Hydro Dissector and a variety of knives to be used for ESG. Some of them are mentioned here, like hybrid eye knife, a dual knife, IT2 knife, nano knife, injectors to start the dissection or raise the mucosa. We also need to have available hemoclips, the coag grasper for coagulating. We need to have the clutch cutter or endoscopic scissors, and of course, clips like Ovesco and the Apollo endoscopic suture in case of complications during the ESG. There are several techniques to perform ESG that I'm going to mention now. The usual technique is a circumferential submucosal dissection, elevating the submucosa and resecting it circumferentially. As time has gone by, there are other techniques that facilitate ESG, like the pocket creation and tunnelization that helps us resect large tumors. Submucosal tunneling endoscopic resection or STIR, or submucosal tunnelization, or EFTR, that is full thickness resection of the submucosa. This video shows how we see that we need to mark the borders of the lesion. It is marked here. We first select the site where we're going to start the dissection. We inject saline solution with methylene blue in the submucosa so that this solution pushes the muscle layer and helps us create the third space as we are seeing here. We continue doing the dissection, and please see how important it is to maintain a broad third space so that the dissection is made broader and broader. We may go directly to the blood vessels and coagulate them with a knife, or if necessary, we may use the coag grasper. This is the traditional method. However, we have the pocket creation method that help us achieve greater security when mobilizing the lesion. This is an evolution towards tunnelization. It was created in 2013, published in 2014. A minimum incision is done as we see on the right side, and the dissection is done under the lesion with the tunnelization until we go beyond the lesion. This helps us keep the endoscope tip stable. We are synchronized with the patient's movements. If there is fibrosis, we may perform good dissection, and it helps us maintain a good distance between the endoscope tip and the knife in the submucosal tissue that we are dissecting. STIR, or submucosal tunneling endoscopic resection, allows us to dissect the lesions, sparing the mucosa. In these cases, we're not going to dissect the mucosa. We inject methylene blue and saline solution 3 to 5 centimeters proximal to the lesion. We start tunnelization by elevating the submucosa until we find the tumor, and we dissect with the different knives. We dissect or completely release the lesion. We resect it, we perform hemostasis, locate the probable bleeders that could cause late bleeding, and we close the mucosa with hemoclips to have a complete resection. This helps us perform complete tumor resection, maintain or leave the patient with free margins to prevent tumor recurrence. Given that we have intact the entire gastric wall or the wall of the organ that we are treating, we need a shorter length of stay. There's quicker recovery of the oral route. In 24 hours, we can start clear fluids. We achieve complete unblocked resection of the lesion in more than 80% of cases. And very importantly, it allows us to spare organs. the organ that we are treating. This is a submucosal lesion very close to the gastroesophageal junction. A window is created. We resect it through the submucosal space until we can completely resect the tumor, and we close with hemoclips to be able to close the mucosa. What are the benefits of STIR? It keeps the mucosa intact, as we said before, a quicker healing, lower chances of infection, and lower chances of leak of the gastric content. Another technique that is widely being used is endoscopic full thickness resection. It is preferred for lesions that involve all of the layers, the muscularis propria and the serosa. If there is extranumeral growth, unfortunately, or there is EFTR is indicator, and we may also use laparoscopic surgery using laparoscopic assistance in some cases. It necessarily requires a suture to provide full closure of the wall. This will avoid gastric content leaks and prevent peritonitis. How is this done? The entire mucosa is cut and the entire tumor circumference. There is a circumferential incision that includes the full muscularis propria around the lesion and the serosa around the tumor. We resect the entire lesion, including the mucosa, the submucosa, the tumor, the muscularis propria, and the serosa. We need to very strongly suture the perforated wall with hemoclips if it is small, or with an endoscopic suture if the lesion is more than 2 centimeters. This is a video of a case that we treated last year. This is a submucosal in the mid-third of the stomach. With virtual chromoendoscopy, we decided to perform tumorectomy or tumor resection endoscopically with nodes. We are now elevating the submucosa. We are creating a window as we do with POEM in order to create the submucosal tunnel. We are opening up literally as if this were a POEM procedure. We are creating the submucosal tunnel until we reach the tumor. We start very carefully dissecting all around and coagulating the blood vessels that we encounter. We tried to resect the tumor, but it was too adhered to the mucosa, so we decided to resect the superficial mucosa. We are starting the cut of the sides of the mucosa. We are looking at the mucosa from inside the tunnel that we have created. We are now dissecting completely the mucosa. We are cutting all the sides. This has been resolved. We are using now the endoscopic scissors for this last segment of the lesion until we can achieve complete release of the lesion. And we will go in for a final review. We have released this submucosal tumor, including the mucosa, and the tumorectomy was done. And in the final check, we saw that the muscularis layer was intact. We didn't cause any trauma to the muscularis propria. And this lesion remained open. We did not require to close it. The patient was discharged the following day. This is data from a paper that we are going to publish together with Dr. Michel Kahaleh, who has been my professor in the past 5 years. He's also my friend and a very good person. This is a report of 39 patients. We treated 1.1 lesions as a mean for a total of 74 lesions in whom we did ESG. These are the locations of the lesions, most of them in the prepyloric area, 65%, 15% in the antrum, in the incisura angularis, 6.7%, and also other locations. According to the Paris classification, almost more than 50% of them were 2A lesions. We performed complete dissection in 100% of the cases in the 74 lesions. In none of them did we have any complications, fortunately. So this is data that we are about to publish together with Dr. Michel Kahaleh. I would only like to tell you to close that this has been a long learning process. More than 50% of the cases that we are about to publish, I had the fortune of having beside me my instructor and professor, Dr. Michel. We are currently participating in the education of other physicians on this technique. Lastly, I would like to invite all those of you who are interested in learning these new techniques for ESG and POEM to the course on March 11 and 12 of 2022. We will hold for the Advanced Therapeutic Endoscopy course. Thank you very much for this opportunity to share this podium with you. I will be available for Q&A. Many thanks, Dr. Juan Carlos Caramés. This was a very interesting presentation. Your statistics were very, very nice. We have received several questions. Dr. Arturo Sanchez from Nicaragua has a question addressed to Dr. Kahaleh. What has been the biggest challenge that you've had in interventional ultrasound? This is a very interesting question, a very good question. I think that there has been a tremendous progress that allows us to offer anastomosis. Therapeutic endoscopic ultrasound is allowing us to create anastomosis, and this is creating things, changing things. If you want to do a gastric bypass to connect both stomachs, to do ERCP, or a patient with pancreas cancer who requires, who needs to eat, well, believe me, this kind of anastomosis will completely change the way in which we manage complicated cases and many conditions. Another question is the difficulty in hepatico-gastroanastomosis, in keeping with the same question. The problem that we have with hepatico-gastroanastomosis is that for a long time we have been looking for better instruments to facilitate the procedure. For instance, when the biliary tree is very, very much dilated, it's easy to access the biliary tree. However, there are many companies who are working now to provide accessories that will facilitate this access. Boston Scientific, Medtronic, they are all trying to create accessories that allow us to have access to the biliary tree and place a stent, for instance, for hepatico-gastrostomy or hepatico-gastric anastomosis. Dr. Caramés, what is the size of the submucosal lesions? Is there a size limit for ESD? Size limit for lesions for ESD, or the depth is more important? Thank you for the question, which is very interesting. There is no size limit. I had the opportunity of being in Japan with Dr. Morita, and at his hospital, I saw a dissection that involved the entire antrum, more than 15 to 20 centimeters of dissection. The limit should be the depth of the lesion rather than the size of the lesion, as we said before. In intraepithelial or submucosal lesions, according to that are T1A, in which the risk of lymph node invasion is minimum, that is our limit. If we go beyond this, we are taking the risk of having complications or having tumor relapses. But the size of the lesion is not the limit. We've had the opportunity of resecting a 12 centimeter lesion. That's the biggest lesion that we have resected. Does this apply to HIST tumors? Yes. You can treat GIST tumors, of course, if they are less than 2 centimeters in size and diagnosed. was we make sure there is no invasion of other organs. Yes, it's possible to to uh, to treat them, of course, making sure they are not too deep. But we can perform a full thickness resection where we can resect all of the gastric layers and resect the lesion, making sure that we place a mechanic suture to have a very, very secure closure to avoid the leaks of gastric contents. Many, many thanks. A question for Dr. Prashant. The incidence of Barrett's esophagus after endoscopic sleeve gastroplasty, is it similar to the use of a surgical procedure for the gastric sleeve?
This is an excellent question. So far, there has been no publication showing significantly higher rates of Barrett's esophagus after endoscopic sleeve gastroplasty, as opposed to the laparoscopic sleeve where rates of acid reflux can be 30 to 40, 50%. Our rates of acid reflux after ESG are significantly lower because we do not close the fundus. And because of this, we likely suspect we will not see as much complications from acid reflux, such as strictures, Barrett's, and so on. This is still early in the course of this procedure, so we will have to see how things go in the future. But as of right now, it does not look like it's a problem.
Ok. ¿Y al doctor Juan Carlos está haciendo ya la manga gástrica aquí en México, endoscópica?
Sí,
¿Hay estadísticas?
Are we already doing this procedure in Mexico? I'm referring to the endoscopic sleeve gastroplasty. Yes, we are about to present this at the Mexican Association of GI Endoscopy and as the Mexican Association of Gastroenterology. We have a total of 32 cases of endoscopic sleeve gastroplasty. We have been collaborated with Dr. Michelle Kahaleh at Robert Wood Johnson Hospital. We've had the possibility of performing this procedure in Mexico with excellent outcomes, zero complication rate, very good metabolic improvements, and weight loss improvements were similar to the results shared with us by Dr. Kedia. We've had fantastic results that we have already presented at the association. Dr. Kahaleh, how difficult is it to perform cholecystectomy after gallbladder drainage? Placing a stent for drainage purposes. What is happening is that many people now are not used to the concept of endoscopic ultrasound guided drainage. But when you try to explain surgeons how do you drain the gallbladder, what worries the surgeons is how will the perforation be? For instance, if the patient will undergo cholecystectomy, a transgastric anastomosis should be created, not transduodenal, but transgastric. So when we have a patient who is going to require an axial stent after gallbladder drainage, then we place it transgastric because for the surgeon it's much easier if to close it this way. Another question for Dr. Kahaleh. What kind of esophageal stent did you use to rescue the gastrojejunal anastomosis? This is an excellent question. We use the TTS stent, that is through the scope stents. There are not many stents that can go through the endoscope. This is the one that we use. There's only a couple of them, and some of them do not come in many sizes. 20/80, etc. We don't have many sizes. So I think that you should use them when you need to salvage an anastomosis. Dr. Prashant Kedia, this is a personal question. I underwent gastric sleeve surgery. I would like to know when can I detect that regardless of weight regain, or what is the proportion of weight regain that I have to experience to say that my surgical gastric sleeve is failing? And do you think I would be eligible for an endoscopic procedure like endoscopic sleeve gastrectomy, gastroplasty, sorry?
This is an excellent question, and thank you for asking. The definition for weight regain in the surgical literature is not set. It's not a standardized definition. Some say that a gain of 25 to 30% of excess weight loss from your nadir is a criteria for weight regain, and we use some of these type of criteria for our practice as well. So I don't think there's a standard cutoff, but once you feel that your weight regain is going in a path despite behavioral changes that is not able to control your weight regain, this is a time when evaluation of your sleeve should happen with an endoscope to see if there has been stretching or dilation of the sleeve. And with an endoscopic or an upper GI series, these types of things can evaluate the anatomy. And if there is stretching of the sleeve, you would be a candidate potentially for revisional therapy with ESG.
Ok. No depende del tiempo, sino de la ganancia de peso. ¿Alguna experiencia en México sobre
Any
esto?
experience in Mexico about this one, Carlos? We've done only a single case. However, we don't have much experience in a redo of the endoscopic gastric sleeve. But technically, the difficulty is the same. We virtually have a stomach which is almost the same size as the initial stomach, and we may redo the endoscopic suture without greater difficulty.
Muchas gracias.
Many, many thanks.
Por su participación. Agradezco al doctor Juan
I would like to
Carlos
thank all of you for participating. Dr. Juan Carlos Caramés, thank you so much for inviting these internationally renowned speakers.
Muchas gracias.
Very, many thanks to all of you for participating. We hope this is not the last time that you participate with us. Good evening, everyone. I would like to thank Dr. Alma Edith Maldonado for presenting this luxury program with Dr. Michelle Kahaleh and Dr. Kedia Prashant, or Prashant Kedia. They spoke to us about advanced endoscopy, and also we heard from Dr. Juan Carlos Caramés, an excellent talk of international level. We at the Mexican Association of Gastroenterology feel very proud of this session coordinated by the Gastroenterology Society of Tamaulipas. We should be very happy because the Tamaulipas Society of Gastroenterology is celebrating its 40th anniversary, which is not easy. We're glad to see that this society continues to move ahead, trying to achieve the purpose of the Mexican Gastroenterological Association, which is disseminating knowledge and performing continuing medical education activities so that all Mexican gastroenterologists and endoscopies can be updated. We feel very happy after these excellent presentations. We will continue with our virtual monthly sessions. We hope to see you again at International GI Ecos with an excellent program coordinated by Dr. Miguel Ángel Valdovinos, Dr. Rojas, and Dr. Samarripa. They are the course directors. This will take place on August 19th to 21st. This will be a virtual course, and we know that the state of Tamaulipas will be participating also in a meeting of the Northern Region taking place on September 3rd and 4th. This surprise is that the National Mexican Gastroenterological Week on November 12 to 19 will be held in the blended or hybrid mode, on-site and virtual. We are eager to continue to holding our person-to-person meeting, so we hope to see you there. Thanks to everyone and good evening.